Okay, guys, welcome. Thank you for joining us today. Dr. Ryder is going to be giving us a good talk on PI or SID, and he's the man, the myth, and the legend of immunology. And you know us, you guys, most everybody that's on our that are visiting today has been here time and time again. But I'm Angie. I'm a nurse. I run a pediatric clinic, and Dr. Ryder, he works for Virginia Tech in the immunology clinic, and he is also research. Nick, what all do? You do tons of things.
I don't know, but I thought it was November 5th, not April 1st. The man, the myth, the legend. This is great.
Oh my goodness. Oh my goodness. You know you're fantastic. But I'm going to go ahead and let him take over, and I will talk with you guys at the end.
Thank you, Angie. It's a pleasure to be with you all. Again, thank you so much for joining and spending time with us. We know everyone's super busy. So our intent in PEPI or Project Echo for Primary Immune Disorder is always to bring really relevant topics, especially topics that would be beneficial to our colleagues in primary care, especially those individuals working in rural spaces, although we're happy to help anyone. But we want to do it in a time-sensitive manner because we know everyone's busy, and even during your lunchtime. I know that you're grappling with many things. So thank you for your time. So today we're going to talk about primary immune disorder or secondary immune disorder, and I would, like to title this "Diving Beneath the Surface." And so, well, the bulk of the talk will be a case presentation where we kind of dive deeply into that case presentation, and then ultimately provide some conclusions and talk a little bit about secondary versus primary immune disorders. So this case starts with a 20-year-old female. She presented initially with weakness, fatigue, and 2 weeks of cough and a 20-pound weight loss, so pretty significant. Her exam findings, I'm just sharing some of the pertinence. She was afebrile when she presented to our center. She had a relatively low pulse at 62 beats per minute. Respiratory rate was 16. Her blood pressure was slightly low at E4 over 69. Her pulse ox was 100%. In addition, she was strikingly cachectic. And you see in these pictures, this is her right arm. You see tremendous loss of muscle. And then this would be her left leg in panel B, shown here. And she also had what you can't see is some hair loss, patchy hair loss on the scalp. And then this rash, which I would describe as a macular rash that was erythematous or purple evanescent in color. She also notably had right upper lobe diminished breath sound. So just to share some labs, we'll come back, just some high level labs. What you see here, and I've highlighted these for you. She was a little bit anemic, and then her hemoglobin was 9.7. She also was fairly lymphopenic. If we do the math on this, her absolute lymphocyte count was hovering around 480 cells per microliter, so pretty significantly low. We'd love to see that, well over 1,000, 1,100, 1,500 in that range. So 2 to 3 times below the lower limit of normal. And then some just chemistry labs. There were a few abnormalities that were more subtle, but her prealbumin was very, very low. You can see that her value was 4.2 milligrams per deciliter with a low limit of normal of 18. And as many of you know, prealbumin is a very important marker, kind of more time-sensitive marker of nutritional status, a little bit better than albumin. So very, very low value there. And then because of these diminished right upper lobe breath sounds, we did get a chest x-ray, and you can see here that she had this kind of opacity in the right upper lobe. It was patchy, which led to a CAT scan, CT scan of the lungs. And so I'm just showing you one slice, one coronal section, or I guess this would be a transverse section, forgive me, of the lung. And what you see, of course, when you look at this, you're looking kind of up from below. So the right side is on your left. So the right lung is on your left, and the left lung is on your right. So what you see is this destruction of lung tissue, this very opaque region. Black is air, white is bone, and then kind of in between black and white is gray, and that can be tissue such as fat and so forth. So what you see is this cavitary lesion in the right upper lobe, which is consistent with her right upper lobe diminished breath sounds. So just a few more labs, because we're thinking about immune disorders, especially in someone who's lost weight, failure to thrive. and has infection of the right upper lobe, presumably. So in table 3A here, and again, this case was published. I maybe didn't mention that, but you can find the details of this case for the details of this reference, because we thought it had tremendous educational value, which is why I wanted to share it here with you today. So table 3A really shows normal antibody levels, normal immunoglobulins across the board. So she didn't show, you can see her IgG was 1140, very robust. She didn't show evidence of a humoral immune defect or reduction in antibody production. Similarly, her complement studies largely were normal. C3 was unequivocally normal. C4 was just a hair low. We didn't think that was terribly significant. And her measure of total hemolytic complement and the amount that lyses 50% of target cells, or the CH50, was within the normal range. But because of her striking history, we went beyond this kind of first tier immune evaluation, the antibodies, the CBC, the nutritional markers, and moved on to some more detailed investigations of our white blood cells. So table 3C shows you some T cell, B cell, and K cell markers. And what I'm highlighting for you, because there are a lot of markers there, is that this one CD3 negative, CD56 positive, CD16 positive cell count was quite low. It was 8 with a lower limit of 45. So what is that cell group? What do these markers indicate? These are NK cells, or natural killer cells. But you can see the CD3 cells, which is a marker for T cells, was largely normal, nothing concerning there. The CD19 cells, or the B cells, the antibody-producing cells, were within normal limits. And then some of the other indices were also normal. So her lymphocyte phenotyping largely showed low NK cells. But because of this right upper lobe finding, some TB-specific studies were done, because as many who are attending know that TB has this kind of predilection for finding its way to the right upper to the right lobes of the lung, the apices of the lung. So she had a T-spot done, which is a laboratory test that measures essentially interferon release to TB. That was positive. Quantiferon gold is a little bit less specific for TB, was negative. The sputum culture and smear, so this is a produced sputum culture that was sent to the lab, and that was positive on staining for acid-fast bacilli. Her skin test for TB was negative at 48 hours, and she also had a Mycobacterium tuberculosis PCR in the sputum that was negative. So very interesting. She's got this clinical picture of a right upper lobe cavitary lesion, which goes along with TB potentially. And she does have positive acid-fast bacilli on the sputum or the culture, in this case, the smear, which could also go along with TB. But both her her quantiferon gold and her skin tests were negative. So what is this? 12 days later, the culture actually grew out Mycobacterium kanzasi, so a different form of Mycobacterium than Mycobacterium tuberculosis. So what do we have here? We've got a patient who may have a primary immune disorder, or she may have a secondary immune disorder, but she clearly has some evidence potentially of immune dysfunction, in that she is not growing well. In this case, she's lost weight. She's an adult who's lost a tremendous amount of weight. She has lymphopenia, whether that's primary or secondary is up for debate. She also has this right upper lobe cavitary lesion of Mycobacterium kanzasi, pulmonary infection, and NK cell cytopenia. I'd also add here that she's also, her laboratory findings are also suggestive for potentially a nutritional abnormality. So let me just pause there. Anyone in the room, the virtual room, have any thoughts, uh, interest in next steps, additional studies? Does this strike you in any way? Do you think, aha, this is clearly a primary immune disorder? No, 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 no. This is secondary immune deficiency. Or, Ryder, you're all wet. This is something else. I know exactly what the diagnosis is. So any thoughts? And you can either put them into the chat, or you can, and Angie will let me know what's in the chat, or you can just unmute yourself and speak up. I wish I had some Jeopardy music that I could play, but you definitely don't want me singing. Any thoughts? Angie, anything in the chat? The questions are rolling in the chat, you're saying? They're coming in too
No,
fast?
no. Um, So Monica wants you to sing. Can you do that for us?
Oh, that'll be in a future echo session, Peppy session, just to, keep people in with bated breath waiting. All right, no problem. We don't want to stress anyone out. It's already kind of a stressful day. Um, so let me just tell you essentially what happened with her. So often people come into the hospital, right? And we kind of address their primary problem. We think we've done a good job, and we often maybe discharge them for a variety of reasons. Obviously, we don't want people in the hospital for prolonged periods of time where they can get other infections or complications. But this did give us an opportunity because this patient required a prolonged hospital stay to really understand more about what she'd been dealing with before she got sick, what led to her presentation. And so with more just dialogue with this individual, we understood that she really had an eating disorder, and she was self-imposing restrictions upon her calorie intake on a daily basis, and this has been going on for many months. And then she also had a lot of depressive symptoms and a lot of kind of life circumstances that were leading to this depression. So she was engaged with mental health providers, psychiatrists, and psychologists. She was also treated with nutritional repletion, so dietitians and nutritionists very helpfully got involved. She was given RIPE therapy or rifampin, isoniazid, pyrazinamide, and ethambutol for her mycobacterial disease, and ultimately completed a 1-year course. She did have a PI gene panel that was negative, and she was monitored very closely as an outpatient for those 12 months that she was on antimycobacterial therapy. So she continued to kind of have off and on fluctuations with her weight, and then was eventually lost to follow-up. I think I did see a question maybe come in, but for some reason the chat isn't popping up for me. Angie, did you?
No, sir.
Okay.
There's not.
Okay. It's just me hopefully wishing. No, just kidding. So conclusions, primary versus secondary immune deficiency. I mean, this is really vital, and I would be interested in the group's thoughts on why this is important. But for this particular case, this patient's clinical history fit most closely to secondary immune deficiency, secondary to severe malnutrition, which was due to her eating disorder. This probably led to her mycobacterial disease because she ultimately got so sick and nutritionally depleted that her lymphocyte count dropped. So she was, she had a secondary immunodeficiency due to her nutritional status. She'd formerly lived in an endemic area of Mexico, which could have predisposed her to Mycobacterium kinzasi. And she did have clinical signs and symptoms, however, really of both primary and secondary, immunodeficiency. So, these could be absolutely indistinguishable at the superficial level. So really diving deep is critical, which gets to the thorough history exam and appropriate laboratory evaluations. And also, I think it's important to note that genetic testing can be very helpful in kind of ascertaining whether somebody has a primary defect. Certainly, if you find a pathological variant in a gene that's known to cause a primary immune disorder or inborn error of immunity, that's going to help you clinch the diagnosis. Whereas having a
Nick?
normal gene, yeah, hold on, let me just finish just for a sec.
Okay.
Having a normal gene panel doesn't necessarily exclude primary immune disorders, but can help. Yes, Angie.
Check the chat box. Dr. Borsch has something in there and has a question for you.
I may have to pop out of my slides. Can you read it to me? I can't see
Yes,
the chat.
the NK deficiency is out of proportion to all of the other lymphocyte subsets. What's that about? And NK
Yes.
deficiency, you would not expect a myobacterial disease that just a red herring,
Yes.
I'm sorry.
Fantastic point. Thank you, Dr. Borish. Yes. Yes, in fact, the NK cell deficiency, and there is the chat. It's kind of intermittently coming out in and out for me. Yeah, thanks, Angie. So Dr. Boris is 100% correct. The NK cell cytopenia would not explain this clinical picture. In fact, the patients with NK cell defects often have problems with herpes viral infections. So, perhaps if she'd ever had varicella, chickenpox, or potentially even had been given the vaccine, she could have a reactivation of zoster with either chickenpox or with shingles. So this is not a typical presentation of NK cell deficiency. What we do know about NK cells is they're incredibly sensitive to stress. They're incredibly sensitive to a variety of medications like steroids. And so It's kind of like anything that stresses the system can cause a profound NK cell cytopenia, which is why, the diagnostic criteria for either a functional or a classical NK cell deficiency really require at least two, if not three, NK cell measurements and a functional NK cell assessment. So not only knowing that the NK cells are low, but they don't work well. And I'll say that to address Dr. Boris's astute comment, we did do NK cell functional assessment on this patient. And her NK cells actually worked well. And over time, her NK cells did improve as she became more nutritionally replete. So very, very good point. And absolutely did not fit with the clinical picture, which was another reason to say, aha, she may have something else going on besides a primary immune disorder. And so just to kind of wrap up, secondary versus primary immune disorders. I mean, it's really important to think about the causes of secondary immune disorders because HIV obviously is a profound depleter of CD4 lymphocytes. So a very important form of secondary immunodeficiency, as is the most common form of secondary immunodeficiency worldwide, which is protein calorie malnutrition. Other causes of SID would include medications such as radiation or cancer, chemotherapy. Cancer itself can cause secondary immunodeficiency as metastases, invade important immune regions. And then immunosuppression, us secondarily suppressing someone's immunity to preserve a graft post-transplant or for autoimmune disease. And then splenectomy is also an important cause of SID. So it's important to kind of keep these in our differential diagnosis as we're thinking about patients who may present with a clinical picture of an immune deficiency and really try and delineate, does this person have a primary or secondary cause? And then I think, of course, here's our information for PEPI, both our YouTube link, our QR code. Please email us at info@echopi@gmail.com. With that, I'll close the presentation, but I would be very interested to hear from anyone who, had thoughts on this presentation or, even just considerations about evaluating patients' PI status versus secondary immunodeficiency or just any other comments. The floor is open. So let me just throw this specific question out. Does anyone have thoughts on genetic testing and how useful that is in delineating PI from SID? No. Okay. Well, let me follow up that question with a thought. And that thought is that, at best, we see that, the yield for genetic testing is about 40% in someone with a robust clinical phenotype. So genetic testing, while very helpful, positive predictive value can be very high. And certainly if you find a pathogenic mutation in a gene that's known to cause PI, this could be incredibly helpful. Negative findings, non-revealing findings don't rule PI out. So if you still have a strong clinical suspicion that the patient has a primary immune disorder, then we continue to drive towards other functional tests that may be out there, reaching out with colleagues in the field who can do research level functional testing. And we do this all the time in our field. I do
There are
see.
two statements in the chat box. Do you need me to read them or can you see them?
Nope, I got them. Thank you.
Perfect.
So I do see a great question. With the rise in cancer diagnosis, I believe we'll see more and more SID in southeastern Ohio. Thank you for that, Angie. Thank you for this presentation. I look forward to more. My pleasure. And I do agree with you. Malignancy and occult malignancy is a really important thing to think about, and certainly an important consideration evaluating patients who have a clinical presentation of an immune disorder. Larry also said, I think one of the epidemics I'm seeing is rituximab and other B-cell targeting drugs. Any pearls you want to share on those? Yeah, great point. I too see a number of patients who are referred in for immunoglobulin deficiency. And upon actually just taking a history, we learned that they were given rituximab years ago. And we know that a significant proportion of individuals who are given B-cell depletion therapy actually never recover their B-cell function. The determinants of that are not completely known. but those individuals warrant immunoglobulin replacement therapy for sure. And I would say that, hopefully we'll start to see more and more showing up in the guidelines around follow-up of patients who have received B-cell depletion therapy, so that their immunoglobulin status, in particular IgG levels, are tracked over time, because it can take a period of months until that returns to a normal level once someone's B cells have been depleted. But again, some folks, it just never comes back. And those individuals really do need to be protected with immunoglobulin replacement therapy. So yeah, it's a great point. Wonderful. Any other thoughts? Anything else, Angie, that you wanted to share?
Um, I I just wanted to reach out to everyone to make sure that if you look in the chat box, there is a survey that I just, if you guys have a chance to fill that out, that'd be great. We want to know what we can do to improve at. We want to do better, and we want to know what topics that you guys would like to hear from us about. And I also have our email in the chat. If you have any patient case that you want to share with us, de-identified information, please, but you can just email us and we will be happy to reach out to you and help you in any way that you need for guidance for any patient cases.
Thanks, Angie.
And Larry also pointed out something really great. We have some really good upcoming sessions, and we have a vaccine session coming up to where we can talk about how to adequately give vaccines to our immune deficient patients, or just questions and answers. So what we're going to do is we're going to have a panel, and I want you to bring your questions, and we're going to just shoot off any questions that you have, and to help guide you through that. And that is going to be December the 10th. We also have Larry talking December the 3rd about mastering sinusitis. That's going to be great as well. And we just want to hear from you if possible. So take the time and fill out that survey, and take the time to email us if you need us, and come to those upcoming sessions.
Yes, great. Thank you for highlighting that, Angie. Thanks for prompting that, Larry. And I'll just say too that we have this great YouTube site with our sessions there, and there's a friendly competition ongoing right now around who gets the most views for these sessions. So please avail yourself of that. And I don't want to influence your viewing at all, but we would be thrilled if you would visit that and watch everyone's videos, actually. So yeah, right, exactly. But I want to be very transparent, about what's out there. So, but yes, thank you all. Wishing you all a great day. Be safe, and we look forward to the next session. Take care, everyone.
Thank you.